So today we'd like to share with you an interesting case we saw at our hospital last month about a primary brain abscess which was later found to be secondary to nocardia. It's an interesting case because nocardia is not one of the first organisms one would suspect in a primary brain abscess, especially in an immunocompetent patient. So let's begin. So our case was a 56-year-old female who had a past medical history significant for idiopathic bronchiectasis, and she was brought to the emergency department by a family member after she suddenly had a 3-minute tonic-clonic seizure with accompanying speech difficulty, loss of consciousness, and eye deviation. After the episode, the patient was transported to the emergency department after an apparent full recovery. However, during the emergency department evaluation, she presented a new onset generalized tonic-clonic seizure with gaze deviation, which eventually responded to intravenous diazepam. And so we began a full diagnostic workup, which included multiple imaging tests and multiple laboratory tests. We first performed a brain CT scan, which showed a hypodense lesion with well-defined margins in the left frontal lobe. It measured 1.7 centimeters and had associated perilesional edema. Upon seeing the lesion, our main differential was between infectious causes as well as neoplasia diseases. And so our initial workup included laboratory tests to rule out possible infectious etiologies of the possible brain abscess. So we ordered a quantiferon TB gold, an aspergillus antigen, a histoplasma urinary antigen, HIV testing, toxoplasma testing, blood cultures. These tests all eventually came back as negative. We also ordered a chest CT scan, which only showed the previously known bronchiectasis without any further evidence of an acute infectious process in the lungs, so no primary lung process. We then ordered an MRI, which confirmed the findings on the CT scan. Then we performed spectroscopy on the MRI, and the findings were very suggestive of an abscess. So the patient was eventually transported to the OR, where a left frontal open craniectomy for surgical drainage of the abscess was performed. The drained material wasn't for a microbial culture, and further microbiologic analysis of the abscess. We then performed a transesophageal echocardiogram to rule out possible cardiac etiologies of the abscess, but it returned normal. And over the coming days, we continued to be puzzled because we didn't find any organism or any primary process which would explain the brain abscess. There weren't any clinical clues that pointed us towards an infectious process in the heart or the lungs or the skin or really anywhere. We had a urinary culture which was normal. We had blood cultures which returned normal. HIV testing was negative. Tuberculosis testing was negative. And all the cultures from the abscess material were negative for the first 5 days. However, after 5 days, we appreciated small colonies growing, which under the microscope we identified as gram-positive filamentous bacteria, which stained partially acid-fast and also grew on Lowenstein-Jensen media. And coupling the microscopic characteristics of the bacteria, which were gram-positive filamentous rods, with the clinical picture, we established a presumptive diagnosis of nocardiosis. We also sent some of the abscess material to an international reference laboratory in the United States, where 16S ribosomal RNA sequencing was performed. and it was determined that the abscess was due to nocardia abscessus. After that, we modified the empiric treatment, which we had started previously, to now include Bactrim, and we switched the patient of the previous empiric regimen, which included ceftriaxone, vancomycin, and metronidazole. So the patient eventually, but there were many interesting things that we learned from this case. One of them is that how difficult it is to diagnose nocardia, because it takes a long time for it to grow on cultures. In our case, it grew after 5 days. However, it can take up to 3 weeks for a bacterial culture to show nocardia. And also, upon a posterior review of the literature, we found that nocardia can infect virtually any organ system. However, what we didn't know previously was that up to a third of cases can occur in immunocompetent individuals. Previously, I personally held the belief that nocardia was an opportunistic pathogen and that it usually would only infect immunocompromised hosts. Patients with underlying lung pathology, as our patients, are particularly susceptible to inhaling nocardia and having it disseminate into the central nervous system. And the rarity of these infections, coupled with the inexperience most microbiology laboratories have with its diagnosis, make it a challenge to diagnose. So our conclusion is to always have nocardia as a possible pathogen in central nervous system abscess, even in immunocompetent patients, and that if its diagnosis is suspected, the laboratory should be alerted, as it can take a long time for it to grow on media. And if the laboratory does not consider nocardia as a possibility, the cultures may be thrown out. And also another thing that's important to keep in mind regarding nocardia infections is that the treatment lasts for several months after the diagnosis, many times from 6 months to a year. So it's a long outpatient treatment, but we eventually expect a full recovery.